Great, thanks, and good afternoon, everyone, both here and online. I actually was looking, when I was preparing this talk, I saw that the last time I came to you guys to talk about this was 2019. And so actually, we've both been trying, and with COVID notwithstanding, and the international field as well in this area has also been generating quite new and exciting data. And I thought it's kind of appropriate to put, and the reason I chose a quick and easy answer to this, I hope will become clear as we go through the talk. So what are we really talking about? Well, the focus of the talk is beta-lactam. So beta-lactam allergy as a broad group. We're going to talk more specifically about individual beta-lactams. But this is just our framework of kind of what we've considered adverse drug reactions. So if you take a step out from drug allergy and you look at all of the adverse drug reactions, we're trying to sort of move. We used to think about type A and type B, type A being sort of those that are predictable based on the pharmacological action, and type B being sort of idiosyncratic reactions. But probably this is now a bit more of a comprehensive kind of framework to consider these adverse drug reactions. So you still get the on-target reactions, and perhaps for antibiotics, the on-target adverse drug reactions are disturbance of the microbiome. So something like C. diff, you could argue, is an on-target antibiotic adverse drug reaction. And then the group that we're going to talk about today really is the off-target ones. And they are off-target reactions that don't involve the immune system at all. They can be largely cellular or often mitochondrial toxicities that drugs do. And then there's this group of immune-mediated ones. And these immune-mediated ones can also be different in terms of their mechanisms. And what's interesting about beta-lactams as a group is beta-lactam antibodies can actually cause the full spectrum. So they can cause both immediate non-IgG-mediated hypersensitivity through probably other mechanisms of mast cell degranulation. They can cause type 1, what we traditionally know is associated with anaphylaxis to beta-lactam antibiotics. And then they can cause also delayed hypersensitivity reaction, your typical drug rash type reactions, and also some of the more severe cutaneous reactions, as well as even other organ-specific dysfunctions. So why has this really become something to think about? Well, firstly, beta-lactams as a big group are the commonest cause of antibiotic group to cause these immunological mediated hypersensitivity reactions. And really, the figures are quite astounding from high-income countries, where if you look at the inpatients largely, but also in outpatients, you'll see somewhere between 6 to up to even close to 20% of all patients are coming in with a label that they are penicillin allergic, so in a large group, right? And balanced with that large number is still the fact that as a cause of anaphylaxis, penicillins, particularly now immunopenicillins related to prescribing, are actually the commonest cause and can cause fatal reactions. So it is necessary, so it's balancing this labeling group to the severe reactions that occasionally do occur. But what about local data? So there's been total paucity of local data. And so this is our Cape Town study that some of you in this room helped me with. And we tried to essentially survey using a kind of point prevalence survey design, 4 hospitals, actually more than that, five hospitals across the metro. And this happened initially just before COVID, and then we finally got going a bit later, so it was quite a wide time frame, but we managed to sample or survey close to 1,500 patients. And you can see there was a difference between privately funded hospitals and also state-funded hospitals. And what we saw there was that our inpatient prevalence of beta-lactam allergy labels or reporting was just 3%, actually much lower than that figure, right? So sort of half of the lowest end of that high-income figure. So not nearly as big an issue as in high-income countries. What we also found, which was quite interesting, was even within that figure, we did see some discrepancies between our private sector and our state-funded by a significant difference in terms of prevalence. And we can probably have a whole conversation at the end about why there could be differences in that labeling. Essentially, the reason, so that's our actual figure, but now why are people starting worrying about it, and why am I talking to an ID audience? The reason we're talking to an ID audience is because amongst that figure of labeled people, only about 1 in 20 of them are actually truly allergic to penicillin, right? And possibly in children, that risk is even lower, because by far the commonest type of reaction to beta-lactams is a rash in the context of a viral illness in children, right? Which is actually not a marker of true allergy, but is the reason for people getting labeled as penicillin allergic. And then just an interesting sort of figure as a drug allergy specialist is that if you take all visits for drug allergy to the allergy clinic, you often find that about 80% of those patients, once you challenge them, once you put them through testing, you find that they actually are not allergic to that drug that they are labeled as. So that's even beyond beta-lactams as a group, right? Most of them, though, that bottom figure also shows that most of them don't get evaluated. So most people that get the label of a drug allergy in their routine clinical care never get assessed by an allergist, right? And so what about our setting, and what about the challenge? So we now know that 1 in 20 people are not, are allergic. So we've got this huge group of people, and even though it's only 3.2% in our setting, that's still a significant number. And I'll show you the risk stratification to show you in our survey, our actual data, that we still have the majority of those people are probably not allergic. But the big problem really, and the issues and the challenges are summed up in this effort that we've been trying to do. So really what this flow diagram shows is of those 48 people we found in our surveys to be reporting a beta-lactam allergy. Firstly, some of them whether it was correctly done, got a challenge inpatient with a beta-lactam, and that went well. So they got evidence at that point that they actually weren't allergic to penicillin. And then we tried to contact people to come to our allergy clinic at risk. And you can see here, we managed to get hold of 8. Okay, so like some were deceased, we couldn't find a large group, and that really reflects, I mean, those of you that have done research in our setting, trying to follow up people, that's the reality, right? And then even of the 8 that we had, that we found, we managed to get 3 of them to actually come for skin testing, and 2 of them didn't even want to get the next step in the oral challenge, okay? And 1 completely missed the appointment, and 5 of them didn't arrive, right? So kind of dismal. And that was in terms of our effort to actually do this. Nevertheless, we have felt that this is a very important initiative based on, even the small numbers we have, it still adds up to a number of people. And so we've tried to implement a beta-lactam allergy clinic for delabeling. So essentially, we've done several things to try and raise awareness to this. We come and talk to various medical or healthcare practitioners. We've set up a relationship with the pharmacy, so E10 Pharmacy, where we've gone and sat with Barney, and for a long time we were getting pharmacy interns every week when they were reviewing scripts to flag up the penicillin allergic patients, and then Lily would try to track these patients down in the hospital to connect them to our clinic. We've also gone and advertised this to the nursing sisters and the nursing staff, so we've met and presented about this problem to the nursing meetings that happen on a Monday morning. We've done that a couple of times. And there we try to get people. And often what happens is you get a flurry, like in the next couple of days or a week, where you get a flurry of referrals, and then it'll just go quiet. Right? And you can see here, like COVID has been very disruptive, but we've actually got about 30 referrals in this first couple of months. So there's quite a few patients that are coming through this, but you can see here, we're still struggling to get hold of these. So that's the thing. Once you get the names, you still can't connect them, right? And Red Cross have been doing the same. They've actually been a bit better. And I don't know if that's because parents are better bringing their children or whatever it is, but their clinic has sort of systematically gone through it. But I think what's also relevant in this slide is the fact that you can see here, and if you look at the Red Cross data that managed to get hold of most people, look how few. So these are people being referred to the allergy clinic. How few of them we've actually found that have got truly penicillin allergic, right? So the vast majority of these people that even get into the clinic are actually not allergic at all. There's now an extensive, and I showed this slide before, but I'll show some additional data. The reason that you want to do this on an individual level is that carrying an incorrect label for penicillin allergy is bad. Okay? And this relates to actual other ADRs that patients experience, right? So you use other different antibiotics, you can get other different adverse drug reactions like an increased risk of C. diff. And also your primary infection, so treating your primary problem can also be problematic. So there's data that showed an increased likelihood of getting surgical site infections. Right? And also the bottom is it costs the health system more. Right? People stay in hospital longer, the mobility and the costs go up. This is the last 3 years of data. This has been a lot of orthopedic data. But here you can see there's a look, if you looked at just looking at back surgery, right? Patients coming in for elective lumbar fusions or discectomies, you'll see there that the beta-lactam allergy patients had increased risks of sepsis. They had increased risks of ER or readmissions. Okay, beta-lactam allergy in the pediatric Australian study was associated with an increased hospital length of stay, and much relevant to this conversation about antibiotic stewardship. They had almost a five-fold increased chance of getting restricted antibiotics. Right? This was also confirmed in another recent UK study. And the only bit of conflicting data against this overall trend was something that looked at surgical site sepsis. And so maybe it doesn't always increase the chance of getting infection. There's no question that it exposes you to an array of other antibiotics. It has this problem of giving you the much higher likelihood of getting a restricted antibiotics, which has drug resistance problems on a public health level. So, but this data to me is relevant because this is the data that I use to say, why must you come as an individual patient for this problem that you don't think is a problem, but later on in your life could be a problem, right? So this is what I use to motivate individual patients to come, right, to the clinic. And I think, so I think that where we've progressed to is that delabeling, removing these allergies, there's no longer a question that that's a good idea. I think there's several global initiatives, like most hospitals in high-income countries now have these delabeling clinics. But I think the problem, and as I've shown you already from just our local data, is how do you do this? Where do you do it? Who does it? And what happens? So just as a starting point, I think there's been a lot of efforts to look at, can we risk stratify people? And the reason for doing this is we really want to take the allergist out of this whole equation and empower as low a level of the healthcare service to be able to do these delabeling, right? Either directly saying, you know, the reaction you had was not consistent with an allergy, you had severe vomiting after taking a penicillin, and that actually is unlikely to be a problem, or you had headaches and you could directly take away, or actually what you had is you had only a family history, you got a rash during childhood, and the likelihood of you having a reaction is also low. So this, if you just look at this, this is just based on clinical history of the actual event, right? So, and the bottom ones where I drew the line, anything below that line really suggests a very, very low risk. And these things have now been put into, you can find them in a paper algorithm. They've now also been put into a kind of app form. And a good friend of mine and close collaborator from Melbourne, a guy called Jason Triviano, he's an infectious disease specialist that's taken a particular interest in drug allergy. He developed and validated this thing they call the PenFast tool, which is now available as an app. But essentially what it does, you can see how it stratifies people. It's quite simple. They basically say, was the allergy event in the last 5 years? Did you have anaphylaxis, angioedema, or severe reactions in the history? And did your event even require some treatment? And the cutoff they use is 3, so above, so less than 3, effectively, the negative predictive value is very high that you're not allergic to the penicillin, right? So 90, upwards close to 95 if we look at that, right? And I wanted to show that together with that, we use that same tool on the left in that table to stratify those 48 people that we evaluated and we found in the survey. And you can see here that using this tool, 65% of them stratified as low risk. So what that means is of that 48, even though it's lower than high income settings, it still probably represents the fact that the majority of those patients are not actually truly allergic to penicillins. So this is just really to show you like some of the complexities of testing, okay? Because most of the time, if you, the kind of traditional way of thinking about it is if somebody said they were penicillin allergic, what we would do is we would bring them to the clinic, and this would, if they have an immediate type reaction, they fall to the left of this kind of flow diagram, and we would take their history. In adults, we often look at a mast cell tryptase at the baseline to see if this is the first time they've had a reaction. And then what we do is this kind of skin testing, right? And essentially what you're doing is you're putting, in the case of penicillin, you divide it into major and minor determinants. You use a positive control, which is the histamine. You can see it here, making this nice wheel, indicates that the person is reacting. They have been taking antihistamines. You use saline as a negative control, and then you use the actual active PPL ingredient. This is the major determinant bind to proline, which are the amino acid residues that beta-lactams like to form protein haptens with. And you read it after 15-20 minutes. So it's commonplace in the kind of context of an allergy clinic, but outside of that, in routine care, this is actually quite a difficult thing to get done. We sometimes use for giving it higher concentrations. We're really sure we use intradermal testing, where essentially we use a lower concentration, we inject it into the dermis. That gives us access of the allergen to direct antigen-presenting cells, so it improves the likelihood of getting a reaction. If we have somebody with a delayed rash, we can also do delayed intradermal. So we do exactly the same, but we bring the patient back after 24 hours to read. But all of these things, and also if you want, you can do some laboratory tests and measurements, but these are all quite expensive, quite laborious, right? And are not easy to do outside of an allergy clinic. The other thing about them is that they are not always very useful in terms of the actual predictive value, right? So firstly, they can, and the reason people are reluctant to do them is you can induce anaphylaxis, okay, on the rare occasion, so you need to have the correct equipment to do them. And then this is data to show you here that if you look at patients that had remote reactions, only 20 to 30% of penicillin skin tests will be positive if you're testing someone for a reaction that is 10 years before, okay? And lots of people to a mark, so 100% here, lost skin test reactivity after 5 years from the reaction. So really, like, it's not necessarily that predictive. If you look at when you're supposed to do it, if you've had an anaphylactic event, you can get non-responsiveness immediately after it, so you like to delay the testing, which creates a difficulty getting hold of people. And all of this data, to me, really emphasizes that, and we see this a lot in drug allergy, that the gold standard, the most effective method is direct oral challenge, right, to get to delabel someone effective. And it shows you, and this data, and there's a lot as well in the literature about this, that it's challenging even in a high-income setting where they've got, 100 times more allergists in the South African setting. So really, to me, in this field, oral challenge is the way to go. We've got different methods of oral challenge. The one is just give the person direct full dose oral challenge. But if you've got a high-risk history, what we often do is give people graded challenge, right? And a lot of the time, what's being talked about is using 1/10 of the dose. Right? So that's a good, if you're worried about it, you can use 1/10 of the dose, wait an hour, because the majority of these immediate life-threatening reactions are happening within an hour, and then you can follow up and give a full dose. And you can see here that the negative predictive value of oral challenge for immediate hypersensitivity is 99%, and even actually for these non-immediate reactions. So really, it's the most effective method. The question, though, that everyone keeps asking about this is when is it safe, and how should we perform it? So the one thing that people are trying to do, this is data from another close collaborator, Kim Blumenthal, who's been very instrumental in the American allergy environment working with this issue, is to try to develop these kinds of algorithms in hospitals, which allow, again, if you look at the top there, it allows people that are working or speaking to the patient some guidance as to what we classify as the different types of reactions. And then based on that history, simply the clinical history around, you would then triage people, right? And this is obviously in the emergency setting. So somebody's presented with a meningitis or a community-acquired pneumonia, you want to now decide what antibiotic to give them in the context of a penicillin allergy. And here you can see this is the more delayed hypersensitivity reactions. Okay, there we should avoid completely. Here on the other corner is these mild reactions, patients with a minor rash, itch. Okay, and there they were recommending here you can definitely go to 3rd or 4th generation cephalosporins. Okay, or you can actually use a penicillin, but just use a test dose procedure. I'm going to show you some data later that this group you can probably use full dose penicillin challenge, right? And then the middle group, which was possibly consistent with a type 1 hypersensitivity reaction, again, you could use a 3rd or 4th generation cephalosporin with the test dose procedure, right? So I think the take-home message is in a hospital setting, really patients that have penicillin allergy labels can get a 3rd and 4th generation cephalosporin with test dose procedures, no problem. This was in a study setting, and they really showed how it increased 7-fold the use of these test doses for beta-lactam without increasing adverse drug reactions. So it was really, really safe, and it definitely decreased the use of alternative antimicrobials and particularly restricted antibiotics. And then this is now Jason's most recent study, which I thought was a really excellent study. And this was using that low-risk algorithm to basically, for these 3 groups, patients that gave a history of an unknown reaction 10 years ago, patients that were like the type A ones that, like I said, had a headache or some other kind of GI symptoms that were not consistent with allergy, but didn't want to have the allergy just scratched out their folder. And then the last group is patients that had some kind of remote localized injection reaction or a mild rash, okay, in a long time. And basically, during that 2-year program in Melbourne, in a single center, they had over 1,300, so a very big group, right? And during that, they identified close to 500 people that fitted this low risk criteria, and they gave them direct amoxicillin 250. There was some variation in the dosing there, so a couple of people didn't get quite that dose. But you can see here, of all of those 478, they only had 4% with positive challenges. But I think the important part, even on looking at that, is that only 10 were consistent with delayed rash and 1 immediate rash. 10 were non-immune, so some other mechanism, and in only 4 where they needed any kind of treatment, and none needed adrenaline. So really, even the positive reactions were a small group, and most of them didn't need. So to me, this is like a really strong support that these low-risk groups can just get direct oral challenge. I put this in because this is an ID audience. Okay, and Jason's an ID specialist, and this was really showing, they were comparing here, what did these patients get post-assessment, right? So this is the group here of the cohort that was not delabeled, and this is the group that actually were tested successfully and found to not be allergic with this direct allergy challenge. And you can see here, they got significantly more beta-lactam inhibitors. Then they got much more unrestricted cephalosporin use. So it really made a significant impact on their antibiotic prescribing in hospital. But what about if you go beyond the inpatient setting? Because I feel like the data is really strong in the inpatient setting. Like for this low-risk group, there should be encouragement across the spectrum to directly delabel these patients. There's now some meta-analysis data out there, and there were 5 of these 12 studies that looked at an outpatient setup. 2 used clinical assessments only on low risk, right? So these were the mild cutaneous reactions, delayed reactions, couldn't remember. So the same thing, and they did direct challenge. And here you can see the similar number, right? So the last study was 4%. This overall looked at 3%, right? So not difference in the context of an outpatient setting. And you can see that 17 reactions were immediate. Most of them were mild, no anaphylaxis, okay? And 96% of patients could have their penicillin allergy removed. So to me, like the data is now, I think, quite substantive and overwhelming. And our local data now says basically that we still have beta-lactam allergy labels, although less prevalent and less of a problem than our high-income countries. But still, 65% of our patients are falling into this low group, and hence would be eligible if we were, if as they came into the hospital, we just immediately did direct amoxicillin challenge for them, and we could delabel them. And then I think there's quite a lot of data that the safety of these direct challenges is well established without the need for any intervening allergy tests. But what about the challenges? So the challenges are, one, to get the message out, right? So trying to get doctors and people to pay attention to the fact that actually you don't want to walk around with an unnecessary penicillin allergy label. The one thing that I think is an issue is how to actually practically implement a tool for the interns and for people as people are coming into the hospital, right? What do we need to give patients? Like, do we need just that algorithm that I showed you from Kim Blumenthal's study? Do we need to just list out somewhere, these are the low-risk histories for penicillin allergy? Does it need to go, for instance, on the antibiotic prescribing chart? Maybe that's the place for it. And then who should do this? If you look, again, like around the world, they're trying different things. So they've tried, hospital admission person to intern. They've also got pharmacy-led ones, so when the pharmacists are getting the information, they are actually triaging people to direct oral challenge. I think there's a lot of education still needed, right? Because a lot of doctors have had it drummed into them that penicillin allergy is anaphylaxis, is life-threatening, and like these patients don't need anything. We even need to continue with patient education because there are a couple of interesting studies of relabeling. So patients go through this process and about 5% have their allergy put back, right? So they will penicillin, and I've had this experience too with my own patients. Like the patient will tell you they're penicillin allergic, you'll challenge them, you'll go through this whole thing, you tell them that they're not allergic, and then you ask them like, you know, what did the GP prescribe? No, I told them I was penicillin allergic and I got another antibiotic. So like if some of this stuff, for some reason, is very kind of deep set. And then I wanted to kind of remind people another thing is that, I mean, I'm even guilty of it in this talk, right? I talk about beta-lactams as a big group. The key thing about this, and specifically pertaining to allergy, is the fact that this is a huge group of antibiotics and the cross-reactivity is actually very low. So the majority of people, if you look at now, prescribing habits are allergic or have reactions to aminopenicillins, right? Which means that they cannot handle amoxil and they cannot handle augmentin or co-amoxiclav, and they can't and shouldn't be exposed to drugs that share, cephalosporins that share the same side chain, right? Which are listed here, right? But that's actually a very small amount of cephalosporins. Largely treating them with other cephalosporins, and that speaks to that earlier algorithm I was showing you, is completely safe and it needs to be encouraged. And what we comment, the most common presentation that actually we see with true type 1 hypersensitivity in our clinic are referrals for perioperative anaphylaxis that occur with cephalosporin. And the thing about that is when we prove the patient is cephalosporin sensitive, so they have a positive skin test, all of those patients, without fail, we haven't seen one yet that is actually broadly penicillin allergic. And they just avoid that drug because cephalosporin has its own unique side chain. They can have all other penicillins. They just need to avoid that drug. So that's the other thing is that this concept that people are penicillin allergic, and that crosses out cephalosporins and carbapenems too. So this is the cephalosporin data from Eric Macy, who's got access to the Kaiser Permanente electronic medical record. And he's mined this data to look at the risks on huge numbers of cephalosporin doses. And you can see here that there's a tiny risk that's increased amongst people with the penicillin allergy label for having a reaction to cephalosporin. So, people should not even hesitate to think about using, especially more 3rd and 4th generation cephalosporins in patients with penicillin allergy. And carbapenems are even the same, right? So the only time that I would be concerned about it is if somebody gives a history of a very severe anaphylactic reaction. And even then, the recommendation is to just use a carbapenem, but use a test dose. So in the context of these other antibiotics, there's very few. I know we've had some conversations. Some of you have called me for patients that have had penicillin allergies about the use of carbapenems. And so this is like a very good patient and information to use. So I think I'm going to end there. That's all I've got. But what I've put up here, which I would be interested in discussing with you guys in this kind of forum, is some of these discussion areas. So firstly, related to our own individual hospital. What do you guys suggest? I mean, are there better ways of doing it? You've seen our efforts so far on the clinical front. You've now seen this data on the direct low-risk challenge and the safety thereof. Are there better ways we could directly delabel people? Because it's clear to me that if people are in the hospital, we've got a shot at it. Once they leave the hospital, you can almost forget it. And the chance of getting them back to our clinic seems negligible. I'd be interested for people's thoughts on that finding. I've got my own ideas, but the finding of why we found the different incidents of penicillin labels across our different strata of the healthcare system. And then also the other thoughts about whether or not we should be talking about this to ID forums, to pharmacy forums, and what do you guys think would be the most appropriate direction to help educate this and kind of address this problem. Thanks very much.
Johnny, that's fantastic talk. Thank you very much indeed. If you can stop sharing your screen for, and we'll take questions. If there are colleagues on the call who'd like to ask a question, can you please put your hand up in the chat, and we'll get going on that. And also, if you could put your camera on when you're talking, that would also be fantastic. So Johnny, while colleagues are thinking about things, about their questions, it was brilliant data, thank you, and a great talk. Just I guess it's a self-evident question, but what is the evidence in the literature around people who wear drug allergy bracelets and for penicillin allergy? Are we to expect that all of those have had a severe anaphylactic reaction? And what are your thoughts on how to deal with them?
That's a pretty good question, actually, Mark, and it's not that's not evident in the literature. So, you know, most of these studies that have just talk about self-report, they don't necessarily report data on like how many of those self-reported patients are wearing a medical alert. I actually had the idea a while ago to try and access our own medical alert data to see whether I could contact patients with medical alert bracelets and then try and delabel them. It's still something that I kind of think is not a bad idea, but I can tell you from my own clinical experience that I've had many people that I have delabeled for one or other drug allergy come into my clinic with a big long list of medical alert bracelets. So, you know, in terms of their allergies. So I'm not sure that the medical alert bracelet or other forms of bracelet to drug allergies is necessarily synonymous with a more a severe reaction. So I think taking the clinical history and following those pointers, there's no replacement for that.
No, thanks. I'm going to come to Graham, and I'm going to come to Graham and to Esmita in one sec, but I just want you for clarification, would you? If you have a patient who self-reports an anaphylactic reaction to penicillin, can you just clarify what your approach would be to the use of cephalosporins, monobactams, and carbapenems? So
if a person has a clear report of an anaphylaxis to, most commonly in our setting, it's aminopenicillins, then if you looked at that cross-reactivity data, my feeling is the third and fourth generation cephalosporins are safe with a test dose. That's the safest way. So I follow that Kim's algorithm there. So I would just use a 1/10 test dose, wait 1 hour, and then the full dose.
Okay, thanks very much. So Graham, and then Esmita.
Disadvantage. Sean saying he's disadvantaged here. Okay. Hi, Graham.
Thanks, Johnny. Great talk. I just wanted, on this issue of the delabeling oral rechallenge, if you can just give us some sort of practical advice how you go about that, you know, how long you monitor for, what you look for, and just based on your experience.
Yeah, so we do, she does a lot of our direct oral challenge, but if we've got that low risk group, we would put the person in our clinic in the morning, we check their vitals, see that they're well that day, and then we give them 250 or even 500. I've even done it with 500. I don't think the dose is that important because you want to tolerate a 500 milligram dose, and then we monitor for 3 hours. If the person is fine, they can go home. Some literature report 2-hour monitoring, but you know, we feel like an extra hour is safe.
And you're simply asking them about symptoms?
Yeah, we're simply asking them about symptoms, and if they express any symptoms, we look for objective signs. So we will then measure vitals. We also have got a peak flow. We also use a peak flow measure to see whether their peak flow has dropped. So some people would recommend a peak flow before, but like I say, a lot of that data, if you look at Jason's data, they try to make it as simple as possible. So literally it's sort of observe challenge. Somebody needs to sit in a place where if they have symptoms, they can report.
Yeah.
That's it.
Thanks.
And certainly actually in the hospital setting, like if we do it in an inpatient setting, you know, the person's had their vitals measured. If their vitals were stable, you could keep them in, you could give them the drug, notify the nursing staff that you're doing this, and they could, you know, report any symptoms, and that would be safe. Because like even what that data was showing was that even the positive reactions, very few of them, if any, have shown to be severe.
Yeah.
Thanks. So I'm going to come to Esmita, then I know Sean is wanting to ask a question, and I'd also like to ask Vanessa whether, from a patient's point of view, you have any thoughts on this. But so Esmita, Sean, and then Vanessa. Thanks.
Thanks so much. And that was a great presentation, Johnny. I was there in 2019 for your presentation as well, so it's nice to have listened today. I have one question and then really a comment. I think I'll say the comment first, which is about the lack of education around this, which is so important, particularly for pharmacists as well. I'm a pharmacist, and you know, the way you presented the data today, the way we communicate to people about penicillin allergy is so important, particularly this issue around the low risk with cross-reactivity, which a lot of people aren't aware of, including pharmacists, when they come to deal with penicillin allergies, which is so recurring in the clinical practice that we see daily. So it's really important that we educate ourselves and our colleagues as well as patients on this. The second point is about how you deal with patients' expectations around allergies. One of the key issues we have, and we had a patient sort of jury panel yesterday, and we were talking about this, and all the patient representatives, they were adamant that they had allergies based on anecdotal histories from their childhood, or they had a cousin who had died from penicillin poisoning. And it's so difficult to convince people that these allergies are probably insubstantiated scientifically, and probably these individuals can have penicillin or whatever antibiotic they're supposed to be allergic to. So I'm really curious how you manage the patient side of this and convince them, A, to come and have the testing, and then, like you say, to not go and relabel themselves again.
I mean, I think that's a very good question. We all are struggling with. So you can see that the data suggests that it's quite difficult. Personally, I really try to use that data about the negative impacts for individual health. So that's my strongest point. I'm really trying to encourage people that actually, you know what, if you are not allergic and you're saying you're allergic, that can come with a health cost to you, as an individual. So, you know, I think we might like to talk about, you know, drug resistance and that problem, but as an individual patient, that's not that relevant to them, right? Immediately. Exactly. Whereas we tell them that next time you come to the hospital, if you don't have a penicillin and you're not allergic, you could get another antibiotic that might give you terrible diarrhea or might give you terrible other side effects. So I like that data. I think that's been my most convincing tool for people that I've seen to like encourage them to actually go through it. And then I also think that, you know, like the quicker I can get people to direct challenge, the better. Because the effective method, in my view, is the person must take the medicine and find out for themselves that actually they feel great. You know, I think, you know, some people, and you know, I've got my own theories about patients with multiple drug allergies. Those patients, I feel like, have linked genes to anxiety. So I think there's some overlapping kind of pathologies, which are sometimes very hard to unpick. But to me, there's the quickest as an allergist I can get somebody to sit in front of me and take the drug and feel fine, the better. and very, I mean, I've seen this with, you know, I've done a lot of recent COVID vaccine allergy work. And like the quicker I can take a very anxious person and sit them in front of me, give them a COVID vaccine, the better. Like that's been the most effective way, or get them to some place that they feel comfortable with and give them the vaccine and show them that actually they're fine, the easiest. But it's sometimes not easy, and patients very dogmatically hold on to their allergy.
Yeah.
Okay.
Thank you.
No, thanks, Azrita. Thanks, Sean. I know you're waiting, but because we've just been talking about the patient perspective, I wonder, I don't know, Vanessa, if you would give us your thoughts.
Yeah, sure. Thanks, Mark. Thank you so much. Yeah, so I've been listening in, and Yeah, so as a patient who, I mean, I went through both. I went through resistance and an allergic reaction, but my allergic reaction, we thought, we never really pinpointed it, was to a topical antibiotic. So, you know, this was a surgical site infection that was being treated by both penicillin and Chloromex and Bactroban. And what I had become allergic to was the Bactroban and Chloromex. So, you know, so with my own story, it kind of, we resolved it from rotating antibiotics, you know, going on to different antibiotics because we thought the infection was in the bone. So I don't know if anybody on the call is familiar with my story, but I had a facial reconstruction, overcame MRSA, overcame MRSA, and then I got it back again with potentially an allergy. And when I stopped the Chloromex, and we started rotating the antibiotics, then it started to clear. So it took about 3 months to do that, in and out of hospital. So I think, you know, from my own experience, I think it's important to, you know, to look at all avenues, because if we're talking about surgical site infections, it's not just the oral antibiotic that you're taking, there's other antibiotics that you're taking as well that could cause similar effects. So it could be hives. I mean, I had very, very huge hives on my face. And yeah, and as I say, only through stopping that did I eventually, you know, stop feeling that allergy. So yeah, and I think it's also important to differentiate between, you know, what resistance is and what allergy is, because it can get confusing for patients as well. So yeah.
Thanks very much. That's interesting. I mean, obviously, individual cases, you're not there. It's difficult to comment on, Jonny. But I think, you know, the patient perspective, and I think as Mita, to your question, your comment, I mean, possibly because pharmacists and patients are now getting more interested in stewardship in general, there are potential ways of communicating or piggybacking on the allergy issue as a major stewardship tool, in fact, which it is. Sean has been